Hello, everybody. Thank you for joining me on November 13th. Happy Thursday for differential diagnosis of facial pain. And for those of you that have been to these webinars before, you know that I like doing these because they give us a chance to dive into a topic that I may not cover in a longer format, even though, as I'll discuss as we go today, as I was putting this lecture together, it dawned on me that this could have been a two-parter. So we'll cover off some of that as we go, and I may sort of do an informal part two to this in the new year. I have January set up already, and but I might look at doing sort of the rest of this from a completeness perspective in Feb or March or April. So, in case you're wondering about a couple of things, so was I, and I'll get to that as we go. So, what we're going to talk about today is facial pain, and that is something that isn't always a primary complaint for our patients. It's not something they necessarily come to us with as the main reason they're coming to see us. But as many of you are aware, it's often a coexisting condition with cervical spine conditions and numerous types of headache that we'll talk about today as we go along through the different diagnostic categories here. But I thought it would be useful to start with sort of a definition of facial pain and how it sort of appears in the literature as a defined entity. And really, I put these together from a couple of different papers and sources, but let's call it orofacial pain for a moment. I called the webinar facial pain, but the more true definition is orofacial pain. So I'll use those interchangeably as we go today, but it's defined as pain experienced between the borders of the eyes or the orbital meatal line and the lower mandible in front of the earlobes and kind of above the neck, including the oral cavity. And depending on where you look, some of these definitions also include the forehead, which, as you can imagine, kind of it starts to lump in some headache conditions that we'll touch on as we go today. But that's generally a broad definition. As I'll mention in a moment regarding classification and diagnosis, part of what I did here today for you, hopefully successfully, is amalgamate various classification systems into a way that makes sense for us as chiropractors. Orofacial pain in some of the classification systems, like the ICD-11, for example, has multiple, 30, 35 different subcategories of facial pain and different types of classifications for trigeminal neuralgia, for example, and we'll cover that as we go. But I attempted to simplify it for us, partly because we're not always the ones primarily responsible for diagnosing these conditions. And in some of these cases, in fact, many of them today, our ultimate job is recognition and appropriate referral. But I also think it's something that we should be aware of from a diagnostic perspective. And again, my attempt was to simplify so that you understand what you should be putting in the patient file for a diagnosis. So hopefully I achieved that. So today we're going to go through clinical context, a little bit of epidemiology, recognizing that this is a broad clinical category, perhaps hard to capture from an epidemiology perspective. We're going to talk about differential diagnoses, and you'll notice an asterisk there. And then finally, we'll talk about some clinical considerations. Again, broad strokes, and that has partly to do with some of the things that I omitted because of time and that I will circle back to in future sessions. But from a differential diagnoses perspective, I tried to stick to the more common ones, recognizing that some of these conditions are extremely rare in a way, and you may go through your whole practice career and never see any of it. But again, part of what we're talking about here is appropriate recognition patterns that will trigger meaningful referrals to help your patient get into the right care pathway. So I fit in as many differentials as I could. And again, we'll circle back to that near the end as well. So, some background for orofacial pain or facial pain in terms of clinical context. We know that from the oro category, if someone has pain in their mouth or something that they feel is originating from their mandible or their maxilla or interior portion of their mouth, they're probably not going to show up in your office. They're going to show up at their dental office, or if they have one. However, these things can present in other primary musculoskeletal care settings and medical settings, like our offices or physiotherapy offices or other MSK medicine providers, neurologists in complex cases or more complex cases, I would say, psychologists' offices, ophthalmology, and otolaryngology as specialist consults. One of the things about the face, as you're aware, is very close to your head and brain and cranial nerves. And so there's a lot of kind of complex neurological things that can happen. And that's one of the reasons why I thought it was good to review this sort of thing. And as I normally will readily admit, as I was putting this together for you guys, I learned and reviewed some things that weren't sort of top of mind for me as well. So facial and orofacial pain can be very challenging, and there are a lot of different etiologies that can underlie any given patient's presentation in your office. If we look at these as a basket of conditions and just think of pain primarily from the eyes to the jaw, but again, some of those definitions include the forehead, the population prevalence kind of varies by source. And as I've said before, respectfully to epidemiologists, epidemiology doesn't matter to the patient sitting in front of you, but it kind of can inform us from a policy and systems level perspective. But the population prevalence varies by the source you look at, anywhere from 2 to 33%. That depends on definition as well, which again can expand to include some headache conditions. But what we do know about facial and orofacial pain is that women are generally affected about 2 to 1. We're not entirely sure why. Some of the differences between genders remain a mystery. The default way to explain that away is hormones, but I'm not sure that always stands up to scientific rigor, and I don't think it does in this case, unless I'm missing something. From a risk factors perspective, for having an orofacial pain condition, psychological factors, low socioeconomic status, smoking, and the presence of other chronic pain conditions. And to be honest, you can take that list and apply it to chronic low back pain, chronic neck pain, other chronic pain conditions as well. We know that there's a very distinct interplay among social, psychological, and biological factors. At the time of this recording today, the research review I posted this morning deals with one of the first studies to try and tease out the influence of social factors. In a biopsychosocial model, most of the research to date has been done by researchers looking at biological and psychological phenomenon like pain intensity, anatomical structural damage, and then the psychological stuff like mood, anxiety, depression, and so on. This study tried to pull out some of the social factors like marital status and so on, and found some pretty interesting findings. So if you're into the weekly research reviews, that was the one I posted this week. Smoking remains a risk factor for generally any chronic pain condition. And just like other pain conditions, like spinal pain, for example, we know about 1 in 5 orofacial pain cases progress to be chronic. Those numbers are very, very similar for low back pain as the relevant example for us as chiropractors. And they refer to this in the classification diagnostic systems as COFP, or chronic orofacial pain. It can be primary, meaning it's like a primary headache. It is the pathology, or it can be secondary, meaning that it is a result of some other pathology that has or has not yet been determined. We know that chronic orofacial pain, not surprisingly, also correlates with mood disorders, sleep issues, and general reduced quality of life. And we also know this is rampant in chronic pain conditions in general, that delayed diagnosis is pretty common. And some of these patients don't get the right care at the right time, pardon me, and kind of waffle through the healthcare system to various providers before they get an appropriate diagnosis and then a relevant treatment algorithmic approach to what's happening for them. So if you want to go to sleep for a few minutes, we can talk about classification systems. And I'm actually not going to talk about them very specifically, apart from to identify the ones that I had a look at. These are for diagnostic codes in some places, for insurance purposes in others, and for general clinical research. And you've heard of some of these, I'm sure. But there are multiple systems at play for orofacial pain, including the International Classification of Orofacial Pain, or the ICOP, and that's from 2020. The International Classification of Headache Disorders 3, or ICHD 3, and the International Classification of Diseases, or ICD 11, which is the current version of that. I will not bore you with the gloriously detailed, in my opinion, borderline ridiculous setup of some of these classification systems. But what I've done, hopefully, is attempted to simplify this for chiropractors in practice with regular patients. So, with that said, we're going to get into facial pain differential diagnoses. And this is really about sort of classifying what sort of classification of disease or disorder are we talking about, and then looking for patterns that help you identify those. So these are the categories that we're going to touch on today. And again, as I said earlier, some of this harkens back to kind of board exam trivia for us, but it's funny. I was just emailing with a customer the other day about the degenerative cervical myelopathy webinar that I did last month. And she had realized that one of her good friends had this condition who had never been diagnosed. And what I found, especially early in my practice, is if I went to a nerve entrapment course or something, then the next couple of weeks would just be full of these cases in my office. So I'm not wishing a bunch of complex facial pain cases on your practice, but I think there's some universal force working there, that when you learn about something, you tend to recognize it, or it tends to find you. So we're going to talk about some neuralgias. The main one we're going to touch on there is trigeminal neuralgia. Because of the inclusion of the forehead, we're going to talk about primary headache disorders, recognizing that some of those are topics for another day. There's a condition called persistent idiopathic facial pain, and we'll talk about how you land at that diagnosis, insofar as I'm not sure chiropractors should be diagnosing that. That might be a neurologist or some other ENT specialist doing that. We'll talk about dental and oral mucosa issues that we might recognize, and the algorithm is very, very simple there. Central causes and conditions, sinuses and other rare causes, and then finally ophthalmological disorders relating to the eye or eye socket. So, this is the big one, really. This is the one that if you're going to see in your practice, I think it's the one that might wander into your office, or you may have a patient you've been seeing for years who develops this. It's trigeminal neuralgia, and it's the most well-known cause of facial pain. It involves cranial nerve 5, and we'll go over that briefly in a moment. But it generally provides sensation to the head and face via the 3 branches, and I'll show you those in a moment just for review. And it also innervates the muscles of mastication for chewing. The incidence of trigeminal neuralgia increases with age, typically around 60s or the 6th decade. There's a lifetime prevalence up to 0.3%, recognizing that that kind of epidemiology is really hard to peg down, but it is in the literature in multiple places that trigeminal neuralgia is far more common in those with multiple sclerosis, and about 1 to 6% of MS patients end up with trigeminal neuralgia at some point. That probably, of course, has something to do with the demyelinating pathology involved with MS. More commonly, the second and third trigeminal nerve divisions are affected, and as you're racking your brain to what those are, here they are. The second and third branches are the lower part of the face, basically from the nose down. The V1 branch of the trigeminal nerve is the ophthalmic area up in the forehead, the red area there on the diagram. Maxillary is sort of the cheeks and the upper jawbone, and the mandibular is sort of up towards the thing I always want you to remember about the mandibular branch, it goes all the way up to the side of the head and can kind of mimic like temporal conditions. We're going to touch on giant cell arteritis later on, because I think that's an important one to fit in this differential basket. The other things I'll point out to you there are the nerve branches from the ophthalmic V1 branch that go just above the eye. I don't know if you can see my pointer, but just above the eye, that's the supraorbital nerve that supplies sensory innervation to the forehead. And when we get to sinuses, if I forget to do this, someone remind me after, but there are kind of tender points that you can get to along the orbit on the superior and inferior aspect that can affect those nerves. And in my experience with sinus patients who are acutely sick with a viral infection or something that's bugging their sinuses, or people have chronic problems, can actually be very relieving for them if you put some manual pressure on those nerve points. But those are the three divisions. Also, look in the green part in the back. Those are the cervical nerves that can, through the trigeminal cervical nucleus, also crosstalk with the face and head. So that's always something to remember as well. Back to trigeminal neuralgia. The ICHD-3 describes two main categories of it, kind of split by presence or lack of neurovascular compression. Ultimately, in your practice, unless you have advanced imaging already done, you're not really going to know what category they're in. But broadly speaking, there are two main categories of trigeminal neuralgia. Number one is simply called trigeminal neuralgia, and there are three subtypes of that. And then the second one is painful trigeminal neuralgia, and there are six subtypes there. So I will bore you with those nine subtypes. I honestly don't think it's up to us to precisely identify those. I think part of our job here is to get them more assessment, as I will also show you first line treatment for trigeminal neuralgia is generally a pharmaceutical. So that it's not really we're not guideline concordant first line care for this condition anyway, insofar as the guidelines go. So we will try and get to some answer of just trigeminal neuralgia in general. And if we can subclassify it, then so be it. Ultimately, what you look for is recurrent unilateral brief electric shock-like pains. It lasts for seconds, up to about 2 minutes. It's like paroxysmal attacks of facial pain. And remember, it's more common from here down towards the jaw, the V2, V3 branches of cranial nerve 5. If there's pain in between attacks, they kind of call it classic trigeminal neuralgia, or that other name there to me is kind of dumb, but it's like idiopathic trigeminal neuralgia with concomitant continuous pain. No one's going to use that diagnosis. I would just call it TN and go from there. But here are the subtypes of the first classification of just trigeminal neuralgia. So there's an underlying neurovascular compression component here in classic trigeminal neuralgia. And the presence of neurovascular contact with the fifth cranial nerve has no significance, but the contact with displacement or atrophy. So if you just have contact, some people can actually be asymptomatic there. But as soon as there's contact with displacement of the nerve itself or atrophy of the nerve itself, that's generally associated with symptoms. Second, again, you're not going to really be able to drill down into these anyway necessarily. Secondary trigeminal neuralgia is due to conditions like MS, like we said before, or some other space occupying lesion, usually in the side of the face, be it in the soft tissue or a bony lesion or something like that. The third one is idiopathic trigeminal neuralgia. It presents with no evidence of neurovascular compression at all, or any structural lesion on imaging or electrophysiological testing. It's kind of just there for no obvious anatomical reason. So that's the third classification. Again, in your office, you're just going to recognize the paroxysmal temporary nature of trigeminal neuralgia, and if you can identify a subtype, then so be it. For painful trigeminal neuralgia, this is where they have these kind of paroxysmal attacks of the pain in this branch, or both, or in their forehead as well in some cases. And then they have kind of pain in between that can be described as burning, like a typical neuropathic pain symptom, a squeezing feeling in their face. Remember, the cranial nerve 5 does innervate muscles of mastication as well, in contrast to the facial nerve, cranial nerve 7, that innervates the superficial muscles of the face for facial expression. And they can also get pins and needles, like kind of like funny bone feeling in your face. I had a couple of patients that had that in between their more severe attacks in my practice. Um, the continuous or near continuous pain can also be superimposed with brief paroxysms that are kind of autonomic in nature, like skin warmth or flushing or redness. And that, in my experience in practice, is a little bit more common in women who are around menopause age. So it's hard to know if the menopause makes the trigeminal neuralgia worse, or if the trigeminal neuralgia makes that symptom of perimenopause or menopause worse as well. The subtypes for this type of trigeminal neuralgia are due to something else. So it can be attributable to herpes zoster infection or a post-herpetic neuralgia, similar to what you would see in the thoracic wall, for example, or any other part of the body after a herpes zoster infection. Um, One of the things to remember about that is that it can affect the face. It's more common on the trunk, of course, but facial involvement of herpes zoster is certainly possible. It's funny, I used to lecture about that at CMCC for years. That can also be painful post-traumatic trigeminal neuropathy if there's been some degree of facial trauma. I've seen case reports in the literature of mixed martial arts athletes or boxers that kind of deal with this sort of thing from repeatedly being hit in the face, which most people don't do voluntarily anyway. There's a category of being attributed to another disorder, and then there is the idiots don't know the pathology or idiopathic. For those of you that were at CMCC around my time, that's from Cindy Peterson, our old radiology professor. She used to say, idiopathic means the idiots don't know the pathology. And the sixth one is trauma, which is the most common cause. And this can be from actually dental interventions, all the way up to large craniofacial traumas from accidents or occupational accidents, car accidents, fights, or athletic, baseball to the face kind of thing. So those are the classifications for that. How we treat this, like I said earlier, I didn't find a lot of treatment literature from a chiropractic perspective for trigeminal neuralgia or any of these neuralgias, quite frankly. Um, in my experience clinically, sometimes tissue work in and around the face can be a bit helpful. I've actually used acupuncture on people's face before as well, with varying degrees of success, quite frankly. And I think if I recall correctly, that sort of tended to vary with how well the person responded to acupuncture in the first place. And I think, sidebar, but I think some people respond well to acupuncture and some don't. But first line treatments for trigeminal neuralgia, the first category are anticonvulsants like carbamazepine, which only helps about 2/3 of people, quite frankly. And then the other one that's better tolerated but not quite as effective is oxcarbazepine. Um, it always amazes me how doctors remember, like medical doctors remember all the names of these drugs, but I always trip over them when I'm recording reviews and that sort of thing. So I actually made it through those two, not so bad. From a surgical, if there is something impinging on the nerve, or moving it, or making it atrophy, like I mentioned a moment ago, microvascular decompression surgery is actually way better than it used to be. It tends to be regarded as the most successful option for neurovascular compression as a category of trigeminal neuralgia. About 3 or 4 patients are pain-free up to 5 years after, and there's very low recurrence rate. For a neuralgic condition with an impingement pathology or a space occupying lesion pathology, a 4% recurrence rate after surgery is actually really awesome. There are less invasive options like radiofrequency rhizotomy. However, that tends to be associated in many cases with facial numbness as a common side effect, and the recurrence rates are higher. So, given the choice, if it's determined that you or your patient has the pathology that is amenable to surgery, I would go the microvascular surgery route. For painful trigeminal neuralgia, the one I just went through with the 6 different classifications, of course, appropriate treatment is very reliant on what the initial pathology is determined to be. Other neuralgias. Oh, God, there's other nerves that can do this. Remember, neuralgia is kind of a general term. for things. Let's deal with glossopharyngeal neuralgia. That's cranial nerve number 9. If they have a neuralgia here, this is probably something you might never see. It's not very common at all, but they will get brief electric pain episodes in the ear, like base of their tongue, like inside their head, tonsillar fossa, kind of up and under there and below the angle of the jaw. It can be exacerbated by swallowing. And in some cases, the vagus nerve is also tagged in this neuralgia. And if it is, you can get other symptoms like bradycardia, fainting, or asystole. There's also a nervous intermedius or genticulate neuralgia. And this is where I had to cheat because I don't know, I don't walk around knowing what the nervous intermedius is. I've heard of it. For those of us educated 100 years ago, it's also called the nerve of Reisberg. That I remember. That's how old I am. Or the glossopalatine nerve, which I also had heard before. It's part of the facial nerve, which is cranial nerve 7, and it's located between the motor component of the facial nerve and the vestibulocochlear nerve, which is cranial nerve 8. It contains the sensory and parasympathetic fibers of the facial nerve. Upon reaching the facial canal, it joins with the motor root of the facial nerve at the genticulate ganglion. That's where the term genticulate neuralgia comes from. If they have this condition, they'll have like neuropathic pain in the ear canal that's continuous. This is the nerve that innervates not your ear itself, but the canal on the inside. And it can be occasionally present with a herpes zoster infection as well. I think we do bump into occipital neuralgias once in a while. This would be posterior part of the head and scalp. It's considered rare, but the pain can reach the fronto-orbital area through the trigeminal cervical connections. These are what look like a traditional cervicogenic headache or tension headache with myogenic referral, and those classifications kind of bump into each other sometimes. So those are other ones to keep in mind, not very rare. And into our next category, which is primary headache and facial pain. So these ones, I don't recall ever seeing one of these in my practice, but there are trigeminal autonomic cephalalgias. And this will trigger some like PTSD from board exams for some of you. But these headaches are typically associated with cranial autonomic symptoms. They're generally hard to differentially diagnose with trigeminal neuralgia, especially with the ophthalmic involvement. But these are sawtooth pain, burning, or multiple stabbing around the eye and temple with no refractory period for the headache. So these are pretty severe unilateral temporal orbital headaches that start to bump into differentials like a cluster headache, which, if you've taken my other programs, cluster headache doesn't really have a manual therapy application for us as chiropractors. But for this particular one, there are two kinds here. And these are the acronyms that may give you PTSD from your board exams is SUNCT and SUNA. So both of them have short-lasting unilateral neuralgiform headache attacks. And neuralgiform headache attacks simply mean sawtooth pain, burning, multiple stabbing around the eye and temple with no refractory period. The differentiation there comes in as to whether they have conjunctival injection and tearing. So are their eyes watering at the same time they're having this horrible headache on the one side? Or if they have autonomic symptoms like skin flushing, sweating, that sort of thing to go along with their headache. This, folks, is honestly neurologist level diagnosis, but something to be aware of. And you could look really smart at a cocktail party if you pick that off for somebody. But something that can give someone facial pain. And I think because it generally falls into the category of headache, because in my experience, people that do have cluster headaches also have other types of headaches. So they have tension headaches, migraine, or that sort of thing. So they may be coming to see you and like, hey, doc, it's a little bit different this time. So I think it's important to know about that. Another headache that's worth mentioning here is cluster headache. It's paroxysmal hemicrania or hemicrania continua, depending on which classification system you're looking at. This is unilateral face pain. The differentiating factor with trigeminal neuralgia is that the episodes of pain are a lot longer. This is for those of you that have taken chiropractic checkup from the neck up or my headache e-seminar. I show you some artwork that's associated with cluster headache online. If you Google cluster headache and go to images, a lot of what you're going to see is artwork made by people who have this headache. And it's just like horrifically violent things stabbing into their head. These people are in a really rough shape and generally speaking do not present to chiropractic offices because they're seeking emergency care or waiting in line to see a neurologist. But the diagnosis of cluster headache is made if the patient responds to a treatment consisting of oxygen or triptans, and paroxysmal hemicrania or hemicrania continua requires a response to indomethacin to make the correct diagnosis. These categories are very closely related. Indomethacin, to review, is a rheumatoid arthritis drug that's an anti-inflammatory. So sometimes the response of the headache to the treatment is part of the differential diagnostic process. In our world, of course, you can have cervicogenic headache as well. These are primarily unilateral, although I've seen lots of what I would consider bilateral cases. However, usually one side's worse. This is pain from the posterior neck and head referring or traveling to the facial region. Symptoms tend to vary with certain neck movements, and these generally respond pretty well to manual therapy as long as it's kind of an isolated classification of CGH as the headache. In the literature and in my clinical experience, these tend to overlap with migraines. For those of you interested in migraine, that's next month's webinar that I'm going to do, and I'll touch on that a little bit later as well. And I think in that webinar, we're going to go into some of the reasons why not all migraine patients respond well to manual therapy, but some do. And I think part of that is some of the crosstalk between classifications. In other words, I think a lot of migraine patients have a tension type or a cervicogenic component to their headache, and some migraine patients simply don't. And it's funny, we'll talk more about it in December, but we still don't know a lot about migraine headache, unfortunately. So to revisit our categories, we've gone through neuralgias, primary headache disorders. The rest of these are faster, so fear not, we will get through it. Next is persistent idiopathic facial pain. This is a diagnosis of exclusion when everything else has been ruled out. It typically includes orofacial pain symptoms that are dull, aching, or nagging, and it lasts at least 2 hours a day for 3 months. So this would be considered a chronic pain condition. The onset is typically associated with persistent pain after a minor dental thing, ear, nose, or throat procedure, or some other type of surgery. So this can be kind of prompted or stimulated or started by a poor response to a minor surgical procedure. If any of you have ever had a bit of a numb face after a tooth extraction or a dental filling, that can fall into this category. Even though idiopathic in that case doesn't really apply because I think we know what it's from. Generally speaking, to make this diagnosis, and again, I'm not sure this is a diagnosis we should be making, but there's no clinical neurological deficits and a dental cause has to be ruled out or excluded prior to making a diagnosis. So generally speaking, these people do cycle through their dental professional before being diagnosed with this. Then we have dental conditions in oral mucosa. We don't spend a lot of time looking in people's mouths, but even though, some patients don't have a dentist, and if you practice in a remote rural area, sometimes you may have to find yourself shining your phone light into someone's mouth to see if there's anything bothering them. It's considered to be the most common cause of lower oral facial pain, is means something's happening in the mouth. Remember, the nerves that innervate your jaw and your teeth and your soft tissue in your mouth crosstalk with every other nerve in your head and face. So our job here is very simple. If you look in someone's mouth, be a good doctor and refer to their dentist if you see any redness, inflammation, or if they're reporting pain with intake of hot or cold foods or liquids. That means there's probably some sort of nerve condition that might need a nerve or a root canal or something in their mouth that could be referring to their face or their jaw. If dentists don't pretend to be chiropractors, I don't want to pretend to be a dentist. So if you look in their mouth and see anything suspicious, or even if you don't and you suspect an oral cause, I would refer to the dentist. There are some conditions we should be aware of. One of them is persistent dental-alveolar pain. And for those of you who are a bit older, used to be called atypical odontalgia. Both of them are equally ridiculous in terms of how they sound. No clinical or radiological evidence of disease, and it's often related to a previous dental treatment. This is kind of like, failed back surgery syndrome. There was a procedure done. Now they have pain there. Nobody knows why. Salivary glands can also be affected. Unfortunately, they can also be cancerous at some time. This is characterized by severe lower facial pain, typically occurring before or during a meal when the salivary glands are either becoming or are actively involved in eating. And then there's burning mouth syndrome. Some of you may have seen this actually. There's actually, for all the conditions we're talking about today, it's one of the higher prevalences, almost 2% of the population. It's idiopathic as a pathology, characterized by 3 or more months of daily symptoms being 2 or more hours a day, including neuropathic burning pain sensations at the superficial oral mucosa. And the most common area is the tip of the tongue. So, God, that would be annoying, right? Like to have burning at the tip of your tongue. It's common in females who are peri or postmenopausal, and there is a psychological comorbid association. So if you think of the patients in your practice, I think you may notice this sometimes. The literature will tell us it happens a little more commonly in females. I think it can happen in anybody during a time of extreme stress in someone's life. And I think peri and postmenopause and menopause itself can be categorized as that for a lot of women. You can get weird neurological stuff, and it's kind of an interesting phenomenon that I don't think has been kind of fleshed out in the literature very well. But that's my suspicion about why there's that correlation with women. And sometimes you see something like this after someone's in a car accident or loses a parent or has some other sort of physical or emotional trauma. And I think the interplay among you know physical emotional trauma and the function of our nervous system is something that we don't fully understand yet, but I feel like that sort of touches on that a little bit. Then we have central conditions and causes. There are many possibilities here, including central neuropathic pain from MS. We've sort of touched on that already. And sometimes people have pain in their face because they have a cervical artery dissection. So I'm going to sidebar here for a moment. Acute sudden onset facial pain, especially closer down to the neck and up in the temporal region, should raise concern for a cervical artery dissection. And we know this is a very much a topic for another day. I'm actually going to redo my e-seminar called the dissection connection based on some new evidence that's coming out. I'll probably film that one next year. And some of the regulators in Canada, at least, are interested in making that a mandatory course for us to take to help with symptom pattern recognition and so on. But just as a refresher, we're just going to sidebar on this for a moment. Um, Cervical arteries, including the internal carotid and the vertebral artery, are susceptible to dissections where a portion of the tunica intima rips off, and that can cause kind of regurgitating blood flow. When a dissection happens, the prevailing theory is that that causes headache and neck pain. And to the best of our knowledge, the vertebral artery tends to give you posterior headache, although I've been on some legal cases where they have face pain as well. So the patients don't read the studies, of course. And the internal carotid artery can refer pain you see in the top diagram there to the eye and the temple. And that's important to remember. For those of you, again, that read my research reviews, I've published 2 new reviews on papers about this in the last 3 weeks. Two of them, these 2 papers, I've actually made free for everybody until the end of the year because I think this is really important. One of them I'll touch on here. This is a new systematic review and meta-analysis looking at risk factors for cervical artery dissection in the general population. This is Jacobs. That paper also included Dr. Deb Wright from BC, Katie Pullman from Parker, Scott Haldeman, Sydney Rubenstein. This new systematic review and meta-analysis looked at cohort case crossover and case control studies compared to healthier stroke control groups and found the following risk factors for cervical artery dissection, including vertebral and internal carotid. One of them was genetic, and there was a pretty strong correlation. This is methylene tetrahydrofolate reductase TT. And I find it somewhat hilarious that it shortens down to what I would read as motherfucker as I'm reading through the paper. It's a homozygosity here and also metallic metal proteinase concentration as well. We need more work on this, but I'll just put a pin in this for now. These people had a pretty high risk of this sort of condition, and there is a prevailing thought in the dissection literature for cervical arteries that there is a strong genetic component to this. Our colleague from the United States, Dr. Robert Traeger, has also done a recent study looking at migraine and found a relative risk for cervical artery dissection of 5.91 if they have an aura and 3.6 without an aura. That means they're almost 6 times more likely to experience a cervical artery dissection if they have a traditional classic migraine with aura, which is something we'll talk about in the next section and something that we should be aware of in our clinical practice. Then there are things like minor trauma. Cervical manipulation has been put into that basket before. And also things like connective tissue disorders, oral contraceptives, recent infection, the season, and cardiovascular conditions like hypertension, cholesterol, and coronary artery disease. Those bottom lists, the ones that have kind of circulated amongst our teachings for years, are all based on very, very low certainty evidence. And we need a little bit more work in this area. The other paper I didn't put a slide in here for, I published last week, looked at headache characteristics specifically that are correlated with cervical artery dissection. And the 3 factors that came out of that are no improvement in the headache with the intake of medication, a unilateral headache, and a worsening headache. And so those are all things we should keep in mind and ask our patients about in clinical practice. Next in the list of differentials is sinuses. I think this is pretty common. It commonly goes along with a viral or bacterial infection, can cause dull, constant aches like forehead or ethmoid or sphenoid sinuses, often worse with forward bending. That's one of the ways you can diagnose this. Like if someone's having pain here and up here, say, how do you feel if you bend forward? And they'll be like, worse, 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 because it's pressure coming down. They may also have like constitutional symptoms of a cold or infection and may or may not have a reduced sense of smell. This is caused by inflammation due to allergies, irritants, air pressure changes, viruses, bacteria, or the presence of nasal polyps. Just to review, there's a main frontal sinus here, sphenoid sinus kind of inside your upper part of your eye. Ethmoid sinus is just beside your eye and your nose. And then the main maxillary sinus under your eye. I mentioned earlier when people have headaches related to this because some people have a viral infection. They're a bit stuffy. And then they get a headache that's just different. And they're feeling it like in their sinuses. What I found works really well, if you take your own finger, if you're listening to this or watching it, and go in the bottom part of your orbit, you're going to find a little notch. Can you feel that? If you roll your finger pad just down below, you're now on the inferior orbital nerve, infraorbital nerve rather. And if you hold that pressure, sometimes the patient will say, I usually do this when they're lying down on their back, and they'll say, that feels like my headache. And then I just hold it until that pain goes away. And then sometimes their sinus drains and they can feel it. And you can do the same thing along the top of your orbit. There's a notch in your orbit right around there, and you can just roll up onto it, hold it. On the supraorbital nerve, sometimes I would traction it a little bit. And the nice thing about that is you can do it on both sides at the same time, and it can give these people with this sort of headache or pain in their face dramatic relief, and then you can show them how to do it to themselves. So that's like my little take-home tip for sinuses if you've never tried that. I don't remember where I saw that, who showed it to me, but I've done it for tons of patients over the years, and it can be a dramatic improvement for them. Another condition we have to be aware of is giant cell arteritis. These are patients over 50 with non-specific temporal pain. They can also have TMJ pain and pain with chewing. This is a vasculitis in medium or large arteries, including the aorta and its branches, commonly involving the cranial branches of the external carotid and ophthalmic branches of the internal carotid. This is a medical emergency that can lead to severe health consequences, irreversible visual impairment, stroke, and death. It's one of the reasons I'm going to talk a little bit more about it in my new in-person program that I'm putting together now about chiropractic care throughout the lifespan as one condition that we should recognize. The older diagnostic criteria for GCA or giant cell arteritis, they have to have 3 of the 5 of the following: age at onset over 50 with a new headache, abnormality of the temporal artery being tenderness. So temporal artery you can get at up here, it's superficial. It overlays it's near the temporalis muscle, and if you can feel it, or if they can feel it to a large degree, that could be suggestive of this. If there's redness or swelling there, sed rate over 50 millimeters per hour, or an abnormal temporal artery biopsy. Those are the old diagnostic criteria. They've updated and expanded these. I'm sorry for the small graphic here, but the absolute requirement partway down is they have to be 50 years or older. And all they need here are 6 points. These are the American College of Rheumatology and the European Union or League of Rheumatology, whatever EULAR stands for. Clinically, you're looking for morning stiffness in the shoulders or neck, sudden visual loss, jaw or tongue claudication, a new temporal headache, scalp tenderness. Those are the two things that would generally bring them into our office. An abnormal examination of the temporal artery. And then diagnostic tests include ESR, positive tab or temporal artery ultrasound. I notice how they give that one 5 points. Like if there's a pathology in the temporal artery, that's a home run for this diagnosis. And bilateral artery involvement, or another PET scan imaging through the aorta. A lot of these things we can't do, but if you focus on the clinical criteria above in someone 50 years of age or older with a new temporal headache with tenderness to palpation in that area that they've never had before, it's very much worth getting that person assessed immediately. Then we have rarer causes of facial pain like Eagle syndrome, which is inflammation with or without calcification or elongation of the stylohyoid ligament. Remember this from board exams? Crazy. Symptoms increase when turning your head or palpating the tonsillar fossa, like up under here. You can get to your stylohyoid if you really want to give yourself some neck pain. And sometimes they just inject an anesthetic there and it helps. Other times they just take the thing out, which is kind of funny in a way. And then there's neck tongue syndrome, which you may have not heard of for a while. It's unilateral, sharp, brief neck pain plus abnormal sensation and or posture of the ipsilateral tongue after turning the neck. You could probably go through multiple careers in chiropractic and never see one of those. Ophthalmologic disorders, I believe, are the last classification on our list. Glaucoma is the one to look for with any acute pressure or eye pain, may present as ipsilateral facial pain in and around the eye, probably with visual impairment and nausea or vomiting. This, of course, is a medical emergency, and correct diagnosis in a timely manner is crucial. There's also what's called ocular ischemic syndrome. This is a result of severe carotid occlusive disease leading to visual loss and periorbital pain. Ultimately, if someone comes to your office and says, gosh, my eye hurts and now I can't see, they're being referred to the emergency room immediately anyway. So I'm not expecting you to be a hero and diagnose this. You need to get them for emergent assessment. And then optic neuritis. The highest prevalence of this condition is in young, healthy female adults. This is orbital pain worsened by eye movements. So they will be very, very sensitive in and around their eye when they're moving their eye. And there is subacute or acute loss of visual acuity and color vision. Again, when anything is going wrong with the eyes or the vision acutely on anybody that they're not very aware of what it is or they've had it before, they are being sent to the emergency room out of my clinic at least. Then there's a trochlear headache. You guys remember what the trochlea is, don't you? Without looking at the diagram, it's that little sling of connective tissue that holds the superior oblique eye muscle in place. This is inflammation of this ligament can cause periorbital pain or frontal headache. That would be pretty far down on my differential diagnostic list. And you can also have recurrent ophthalmoplegic neuropathy. This is rare, but they get recurrent attacks of ocular cranial nerve palsies with ipsilateral head or facial pain. So that means pain on one side with a palsy of the eye movement muscles, which again, in a chiropractic clinical environment should be more than enough to trigger an emergent referral for them. Now, you're probably looking at your watch, your lunch hour is almost over, saying he hasn't got to a couple of things yet. I know that. I'm sorry. When I made this outline, I sort of bit off more than I could chew in a way. So there are a few major things here I didn't talk about, but they all deserve sort of another day of discussion from a pathology, clinical perspective, and management perspective. One of those is migraine headache. That's the webinar for December that I will have a code up on the screen for in a moment. My goal with that webinar is to go over some new research about migraine. It'll be a bit of a condition review and a bit of an update on some of the cool things that have been published lately. We also didn't talk about myofascial orofacial pain. Like you can have trigger points in your masseter and your temporalis, your occipitalis, and so on. I think that tends to land and be with more chronic headache patients or people with chronic mechanical neck pain. Can also expand that pathology into their facial muscles and TMJ disorders. I mean, that's obviously a part of facial pain. I don't have my schedule fully made for webinars for February, March, April, May, and June yet, but I think I'm going to put TMJ in there as a good review. And I know my friend and colleague, Dr. Demetrius Simakopoulos, is doing some work in that area. So maybe we'll tag up on that one like we did for the chronic pain one last June. So I did not get to these today. I know they are obviously all potential causes of orofacial pain that need proper assessment and differentials. But again, time for that on another day. So finishing up with some clinical considerations for this. Facial pain can be very challenging, and I think it needs a bit of an awareness and clinical suspicion. As I mentioned earlier, a lot of patients don't primarily show up in our office with these conditions, but it may come up in conversation. It may be something that you realize is associated with their neck pain or their history of whiplash injuries, or if they've been through physical abuse or have a history of fighting sports or other trauma to their head or face. This requires some careful history taking and specific questioning about type of pain, timing of pain. It's kind of like vertigo. You want to know what the timing and the triggers are, and what brings it on. How do you relieve it? How long does it last for? Can I link it to any of their existing MSK issues? Is this a patient with a history of neck or face trauma? Have they had concussions before? Have they had other neurological conditions? Have they had a herpes zoster infection or other viral infection that could land in their nerves? As you know, one of the things we often forget about is asking about a prior viral infection, because viruses, no matter what virus it is, in the wrong person at the wrong time can end up in a nerve, be it one side, both, or generally, and give you some sort of neuropathic signs and symptoms that could be a bit strange. So that's always something to keep in mind. We have to be very conscious of doing a relevant physical examination, including cranial nerves, looking in their oral cavity if necessary, and then also eyes and ears if needed. This is kind of the good doctoring things that we're all taught in school that sometimes we forget about in clinical practice. In summary, I said it a few times. You've probably seen it in your own practice, or if some of you have had this yourself, facial pain can be challenging. It does require a careful history and physical examination, and its management really depends on the diagnosis. We didn't talk too much about manual therapy, chiropractic care kind of applications for these sorts of conditions. And part of that reason is that there's not a lot of evidence there. Most of those conditions we talked about today wouldn't primarily seek care from a physio or chiro, for example, for their symptomatology, but you may have someone you're working on for other things that has some of these things going on. Like I said earlier, for trigeminal neuralgia specifically, I've had mixed success with acupuncture and soft tissue work, depending on their constellation of things that they're presenting with. But this is really an opportunity for us to leverage interdisciplinary care and co-management when necessary. I think most chiropractors should have some degree of a relationship with a dentist, because I know a lot of people come into dentists complaining about jaw pain, and not many of them know what to do about that. So if you have an interest in the jaw, And like I said, I think I'll dedicate a webinar to that in 2026 in the spring. There's certainly an application and opportunity there for co-management and cross referrals. And I've talked to many colleagues over the years that have a great referral relationship with a dentist in their area. It's just one of those things to do. This is really just here for your reference. This is a medical algorithm for differential diagnosis of non-dental facial pain taken from the Ziegler paper from 2021. I'll put it in the notes that I'll send you for this. And maybe what I'll do is put it on its own separate page so it's a bit bigger for you to see. And it just takes you through sort of differentials for the length of a facial pain attack that someone might be experiencing and what to do about that. As I said at the bottom, all the treatment endpoints are all medical. But as I also said, a lot of these things require medical intervention anyway. But our goal here is to get someone to the right diagnosis at the right time and see the right professional to give them guideline concordant care. So I thought this was the best one I could find. I know it's a little bit messy. They have all the short forms at the bottom. And like I said, I'll sort of make this one big enough to see, and I'll stick it at the end of the PDF notes that I'll send you for this one. So that puts us 4 minutes to the hour, which is pretty good timing. Like I do a lot of these, and this was the first time I've ever run through this slide deck. So I think that timing worked out pretty well. Next in season 2 for webinars is diagnosis and management of migraine headache. Many of you are signed up for that one already, but it will be on Thursday, December 18th. Same time, same station, a week before Christmas. Recording will be available for those that hold tickets. And in that one, we're going to go through diagnostic criteria, some new evidence about genetic stuff, tie-ins with other sorts of headaches and other pathologies that I think is pretty interesting. I've been collecting a few papers to bring to your attention. And we'll talk about chiropractic management of migraine in that one as well, and maybe start getting down to the concept of why some people respond well to care and some don't. Because I think that's just the reality we deal with those headaches. For my friends and colleagues in Canada, I've got my new in-person event series open for registration in Thunder Bay, Ottawa, Calgary, London, Toronto, Kitchener, Waterloo, and Alliston, which is near where I live. Those are open for registration starting in early March, actually, and then throughout the spring in advance of our CCO Ontario CE deadline at the end of June. This one, I called it Chiropractic Care Across the Lifespan, Diagnostic Challenges and Clinical Strategies. And here's what I'm going to do for this one. I'm going to split the lifespan into 6 sort of categories like pediatrics, children, teens and young adults, all the way up to older adults. And I'm going to go through a lot of differentials, clinical patterns, and things that you may see in practice that we may forget about, that may require a higher level of good doctoring, doing some of these sort of medical testing, abdominal exams, things that we maybe forget about in clinical practice, and then what to do about it, and some general concepts about shifting care patterns as people get older in relation to how their medical scenario changes and how their symptomatology may change. So that's kind of where I'm coming from for this one. The tickets are selling pretty well. If you're interested in coming, the lowest price tickets are available at the time of this recording. A couple of those events, those tickets are almost gone. I kind of limited the number of them for some of those events, like London and Ottawa specifically are selling pretty well at the moment. So if you have any questions about that, let me know. I hope to see you guys in person. I get a sense that people are looking to come back to in-person learning a little more. The COVID hangover might finally be over. And for those of you in other locations, I'm going to add Winnipeg, Halifax, and Vancouver, and maybe Saskatchewan. I'm not sure next fall, depending on how my travel schedule works out. So I hope to see you there. I'd like to thank those of you that joined me live. I'm happy to stick around for a few questions. For those of you watching the recording, if you have any questions, just send me an email anytime. I'm happy to discuss. And I thank you for supporting my company and my courses and these webinars, and I hope to see you again soon. So for the purposes of the recording, I'll stop now. And for those here live, I'll stick around for any questions. So thank you for joining me, and take care, and I'll see you next time.